this was a really interesting situation that occurred that had to do with patient coming in with two injuries to the same body parts or sequentially developing injuries to the same body parts treated in two locations by two different provider groups. And it really was cause for some thought in terms of, excuse me, trying to decide how to manage this. So dealing with two injuries, the same body part is enough of a challenge. There's an injury to one body part, and before recovery's occurred, injury to that same body part, a new injury to the same body part occurs. How do you evaluate that, and what do you do? It's even worse when there are two or more providers involved. For example, somebody comes into one of the DoD clinics with low back injury, and then along the way develops purports a new low back injury and comes into a second or goes into a second DoD clinic. That happens. And then even more complicating is when they come into a DoD clinic and then have a second injury and go to Pinnacle, now called Align, I guess. And so now we're talking about injuries to the same body parts at two different clinic groups. And occasionally, when those injuries occur, the first injury with one employer and their carrier, and the second injury occurs with a different employer and carrier. So how do you sort this out? What do you do with this? It's not just a matter of what needs to happen from a medical standpoint, but the record needs to be clear about when we're treating things. Where are we? How are the records? It's two different claims. The request and the treatment need to be separate. So here's a case. Late July this year, 25-year-old male works for a local pest control company, reports that earlier in the day he was involved in a motor vehicle accident. Treated by paramedics at the scene, was not transported to ER. He denied striking his head, but felt mild dizziness and headache. He experienced neck pain, upper and lower back pain, as well as soreness in both wrists, left elbow, and both knees. So that was the first injury, job-related injury. And then he returned. This was still the first injury, complaining predominantly neck pain, but also low back pain and some swelling in the wrist. And the wrist portion he attributed to attempting to maintain control of the vehicle as he was spinning around. So neck, lower back, and bilateral wrists. And then 2 weeks later, wrist pain was persistent, but MRI was denied. Physical therapy was authorized. Apparently, the wrists were not an initial complaint. This is an opportunity to determine if this was really a part of the injury that appeared later, but in any event. So then 3 months later, he reported worsening of the neck and back pain after a second motor vehicle accident occurring on the job, had persistent wrist pain, and the employer sent the patient to a different local clinic for treatment of the lower back and neck. So now we've got neck, low back, maybe wrists being treated in two different places. What do you do with that? Who's responsible for what? What are you going to report? So there are two aspects about this. One is, as usual, determine what the patient really needs. Physical therapy to the lower back and neck, OT to the wrists, NSAIDs, muscle relaxant. Maybe needs MRI, possibly needs orthopedic surgery referral, possibly needs pain medicine referral. That's going to be the plan. But we're looking at treatment for those conditions or those treatment modalities for two different situations. And how do you decide whether we or Pinnacle will be treating the patient? When do we stop? Really doesn't work to have two different facilities treating the same body part. So how do you manage this? Well, we need to look at what pre-injury status and maximum medical improvement for both injuries that will determine what needs to happen. The first injury, the one that we saw, pre-injury status would be the patient status just prior to the first injury. That makes sense. What was the patient's condition before, excuse me, the first injury, the first MVA occurred? And hopefully we've recorded that in our first report and in our chart notes so that we know if following that first MVA, the patient was pain-free, had no prior neck or back problem or wrist problem, or had some pre-existing problem, but whatever it was, we should be recording that. And then the second pre-injury status would be the status of the first injury when the injury occurred. And in the next slide, I'm going to pull up our favorite graph and look at it graphically. So the second injury pre-injury status in the patients at Pinnacle would be how the patient was regarding the first injury when the second injury occurred. And then the first injury MMI would be the status when the second injury occurred. In other words, however the patient was when the second injury occurred, that's maximum medical improvement for the injury we're treating. Because if the patient is better or worse after that, that's on the second injury. The second injury MMI would be when all appropriate care had been provided at Pinnacle and the patient is unlikely to change materially in the next 12 months. So when we look at this graph, where are we with the first and second injury? The first injury is the B graph here. And the patient was injured and was having residual symptoms. Pain was waxing and waning and had not recovered. And so pre-injury status for this injury was here. It was asymptomatic. And now a second injury occurred and pain was 6.5 at the time of the second injury. We're not responsible beyond that. We say responsible, is not the right word, but it's on the second injury what happens after this point. So we would say that unless there's some reason to think otherwise, this is the point of MMI for the first injury. This is also the point of pre-injury status for the second injury. So the first pre-injury status would be the patient status just prior to the first injury, down here. The second pre-injury status would be the status of the first injury when the second injury occurred. So the patient pre-injury status for neck pain, if that's what we're talking about, being 6.5 out of 10, that's the pre-injury status. And the Pinnacle would need to know that. Hopefully they've asked the patient, and hopefully the patient would have given them the same information they're giving us. So this is pre-injury status of the second injury, 6.5. Now, so saying the same thing here. So I'm sorry, this, the first injury MMI then again would be the status at this point, 6.5. This is when our care would conclude. And the second injury MMI would be either here, if the symptoms never resolved for the second injury, or it would be here if they came back to pre-injury status, or maybe even got better than that. So MMI for our injury is here. MMI for the second injury is going to be wherever this graph ends up, whatever the patient's condition is when they're just not going to get any better at that point. So the other consideration, and who's going to kind of figure this out in a way is how are the employer and the work comp carrier going to see this and what judgments are they going to make? But from our standpoint, what we need to do is have clarity in our thinking that this is the MMI for our injury. And the reverse would be true if Pinnacle had seen the patient first and we'd seen the patient second. This would be the MMI point for the first injury, and here or here would be the MMI point for the second injury. And so, how would this affect the treatment we're doing? Well, if we're the first injury, my advice is we just stop treatment at this point because we can't have two providers treating the same thing. Who's going to be responsible for care? And really, this is an aggravation. This is a new injury. And once we get on this line, it's really the responsibility of the second provider. So when you see this situation, MMI of the second injury is the point at which the second injury, I'm sorry, MMI of the first injury is when the second injury occurs, and care stops at this point. And I would send in a PR4 because the patient hasn't recovered. They're maximally medically improved based upon that first injury, because anything after that is a consequence of the second injury. If we're the treater for the second injury, then I would say I would try and quantitate the first injury status when the second injury occurred. That's our starting point if we're the second provider. And so the aggravations occurred, and when we determine their MMI, they'll be somewhere between these two graphs or maybe even better. So that's the second MMI. So when we're the first one, we stop when the second injury occurs and conclude that claim, and the rest is on the first claim. But again, in the end, the carrier and the the employer will need to make some judgments about continuing care, how they want to apportion it. So they need to be in the picture. But that's the way to approach this when we see this situation. Anybody have any questions about that? Is that anything? Well, and who will do the PR4? Well, there'll be two PR4s. One will be for the first injury because the person has not returned to pre-injury status. And then there'll be a second PR4 unless the patient recovers fully, in which you'd make a case for just doing a PR2 and not a PR4 because there's no residual impairment, no future medical care needed. But that may or may not happen. So if there's residuals, that second injury calls for a PR4. If the patient recovers fully, calls for PR2.